Assalamu alaikum and good noon. I'm Dr. Nur A, Amin, working and practicing vascular surgery in Ibn Sina family. So, first of all, I would like to thank Ibn Sina Vascular Surgery, Professor Dr. G. M. Mogulushan sir, for giving us the opportunity to present in this stage. And I would also like to thank the IPDI. So, today's topic is how to cross a peripheral lesion. This is very much important. So what we need to cross a peripheral lesion, that is, we must identify the lesion first and we plan for hardware. Then we need a hydrophilic guideware. Then we need a road mapping and some alternate or oblique views. Then we will need catheter. That is, we mostly use in our country, there is a support catheter. And then we also need a long sheath, which our previous speaker tells. So let's identify some lesions. This is a picture showing aortic stenosis and the aortoiliac stenosis. This picture shows the right common iliac stenosis, and the other picture shows stenosis in the right CIA, common femoral artery, and CFU occlusion also. And if you notice closely, there are also a puncture site. So where you can puncture, as my previous speaker tells, this picture will also guide you where you can puncture to cross the lesion. This picture shows a lesion in the right external iliac artery SFA and distal SFA stenosis. So how we can cross a lesion? First, you have to take an angiographic view in the aortic bifurcation. So how you do that? It's a simple way. After the puncture, you will pass the guide wire, that is the 0.35 inch into 150 centimeter diagnostic guide wire. You will put the wire, pass the wire into aortic bifurcation. Over the wire, you will pass a diagnostic catheter. Then we will remove the wire. You will anchor the angle of the catheter, pull it to the aortic bifurcation, but don't force it just to cross the bifurcation because it will cause trauma to the aortic bifurcation. This picture shows in the left side that I am first crossing the wire through the bifurcation, then I am passing the catheter, then I am taking picture to cross my bifurcation. This is a picture video where I am showing how to cross the right common iliac artery and external iliac artery lesion. Here the approach is the brachial artery. I took a long sheath that is 7 French into 110 centimeter. I take the diagnostic picture, then I cross the lesion using a support catheter and a wire. My device, here the wire was 0.35 inch 260 centimeter Terumo guide wire. This is the support catheter. After crossing the lesion, I am confirming my distal position or distal side. This patient also has a distal SFA lesion. So that is the main reason we also went through the brachial approach. So here what I did, or what we did actually, we took a long wire. That is, it's a length, Sultan Sir said, it's almost 300 centimeter wire. So that we shouldn't worry about never lose the access. You should, once you cross the lesion, you must remember you should never lose the wire from that position. If you lose the wire, in the second time, you will face it will be very difficult to cross that lesion. This is the video where the lesion is the distal SFA and the popliteal artery. In the same manner, up to the above the lesion, you will follow the same procedure. You will take a long sheet, then you will pass the guide wire, then you will take the support catheter. Then you push it, try to close the lesion. In this picture, we took the long sheet. You see the more diameter with the beaded appearance, through that there is a wire. In the second picture, there is a support catheter and the guide wire. In the distal end, look, there is a loop, short loop, which is atraumatic. We called it the atraumatic loop. This is very much important to cross an occlusive lesion. In this scenario, unfortunately, we didn't cross the lesion from the femoral puncture. This site is adductor canal. This is a very much common site where we, the vascular surgeon, by interventionist, face difficulty to cross the lesion. So what we did, we go to a retrograde pedal access. So we punctured the patient's peroneal artery, like Dr. Maidul Mahmoud said, through C-arm guided. So we use that technique. We punctured the peroneal artery and we successfully crossed the lesion. This thing is for below knee lesion. For below knee lesion, we have to use some low profile wire and low profile catheter. So here we wire use 0.14 or 1 inch and the length is usually 300 centimeter. We use a guiding catheter, that is the 6 French into 100 centimeter, and we use low profile support catheter, that is 0.14 and 0.18 inch into 150 centimeters support catheter. This patient has a lesion in the posterior tibial artery lesion. It's the same scenario from the femoral axis. We failed to cross the lesion, but via the pedal axis, we crossed the lesion. But you must remember, this distal axis, the pedal axis, you should only use this to cross the lesion. Never try to introduce any balloon or stent, whatever you use, through this axis. Then this is a picture where this is a CKD, chronic kidney disease patient. This patient has central vein stenosis. We used a wire, same guide wire, 0.35 inch guide wire. We used a support catheter and a long sheath. Both 6 French or 7 French you can use according to the size of the vessel. We dilate the central vein. But you must remember, this is a very notorious site. If you over dilate it, there will be disaster. So how we can cross a lesion? There are two types or two ways you can cross a lesion. One is the transluminal, that is through the lumen, and the other is the subintimal, that is you pass the wire underneath the tunica intima. So this transluminal technique, here you cross the lesion using a hydrophilic guide wire. You will take an oblique view and pass the support wire and the guide wire. This is what look like, the picture will look like while you cross a tortuous artery. And this is what look like when you cross a severely diseased arterial segment. What you can do, you can take a low profile wire, you can take a low profile balloon, you pass them, you pre-dilate the lesion. It will help you to cross and treat the ultimate, give the ultimate treatment to the patient. And in all cases or in very common scenario, there might be some dissected vessels. So what will you do? You will take a low profile wire, that is 0.14 or 0.18 inch wire. You take or change the view, that is the oblique view. Then you will put a catheter or the guide wire through the vessel and slowly and gently probe it and try to re-enter into the lumen again. This is what picture showing we often face the in-stent re-stenosis case. In this case, you pass a wire very gently. If you want to ensure that you are within the stent or not, you pass a catheter, give dye, see the position, then do your procedure. This is the picture showing a subintimal technique. This is almost the same scenario like the transluminal technique, but what is the main point here? That you have to cross the lesion in the subintimal way. So how you do it? You identify the lesion. In this case of scenario, there is a large collateral vessel usually. So on the opposite wall, you will pass the wire, pass the guide wire catheter, then cross the lesion. Then when you reach the distal end, you gently probe it and try to re-enter into the vessel. And for this subintimal technique, there is some re-entry device available in the field. I think there is an Outback from Corys, Enter from Medtronic, and Off-Road from Boston Scientific. So what is the tips and tricks? So crossing a lesion, that is the stenosis and occlusion, these are quite different. Stenosis needs careful steering of the wire through the lesion, but in case of occlusion, you have to go blind force. Keep minimal gap between the hardware for better support. If you feel resistance while introducing hardware, never hesitate to change it. And patience is always the key in peripheral lesion. So in this last picture, I just want to show you how the endovascular therapy evolved over this. Even our main book has changed from its main cover, the endovascular surgery and endovascular therapy. Thank you all.
Thank you. Thank you, Dr. Nur A. Actually, he presented the most important part of endovascular therapy.